Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from bioMario, Inc.
Hello, I'm Dr. Trevor Van Schooneveld. I'm a professor in the Division of Infectious Diseases and medical director of the Antimicrobial Stewardship Program at the University of Nebraska Medical Center in Omaha. Welcome to this Medscape program titled Critical Decision Points in Bloodstream Infection Management, Evolving Approaches with Rapid Diagnostics. I'm very pleased to be joined today by Dr. Gonzalo Bierman, who's the Richard P. Wenzel Professor of Medicine and the Chair of the Division of Infectious Diseases at Virginia Commonwealth University in Richmond, and Dr. Stephen Simpson, who's a Professor of Medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Kansas in Kansas City and chairman of the board of Sepsis Alliance. Welcome, Gonzalo and Stephen.
Thanks, Trevor. Good to be here.
Today we'll be discussing the use of multiplex PCR panels for the diagnosis of bloodstream infections. Stephen, from your perspective as a critical care physician, why is it so important to diagnose and treat sepsis quickly and appropriately? And what are some of the challenges we face as clinicians in achieving this goal?
Yeah, thanks, Trevor. The key important thing here is that sepsis is a time-sensitive diagnosis and ought to be put in the same bucket of diagnoses as acute MI, stroke, and other acute severe illnesses. We especially know that in septic shock. All the way back in 2006, my friend Anand Kumar in Winnipeg published a paper showing that delays in antibiotic therapy in patients with septic shock are associated with a 7% increase in mortality for every hour that goes by before antibiotics are given. About 20 to 30%, they went on to show later, of the people with septic shock get inadequate antibiotic therapy up front, or empiric antimicrobial therapy is inadequate. And that's strongly associated with increased mortality, even as much as the delays are. So it's crucial that we diagnose sepsis early and get it treated early. Now, conceptually, that should be easy, right? Because to diagnose sepsis, we need to know, is there an infection? And is there organ dysfunction? And that's the simple diagnosis, life-threatening organ dysfunction caused by a dysregulated host response to infection. So organ dysfunction, it turns out, is the somewhat easier part because we have specific recommended criteria to follow, as in the SOFA score. And even if one goes back to previous sepsis criteria, we have some pretty set criteria that we use for deciding whether organ dysfunction is present. It turns out that diagnosing sepsis is trickier than one might think. So organ dysfunction, yeah, that's present. Is infection present? That turns out to be a little bit harder to decide. There are some specific syndromes that we all learn in medical school, such as pneumonia. For example, a person has fever, a new onset cough, pleuritic chest pain, purulent sputum, and egophony on physical exam. Well, that's pretty much diagnostic of pneumonia before we even get to anything else. Pyelonephritis, maybe, severe flank pain, fever, costophrenic angle tenderness. These are some things where it's relatively easy, but not everybody comes with those, unfortunately. When those low-hanging fruit are absent, determining the presence of infection in a timely fashion can be difficult and it has both low sensitivity and low specificity in the techniques that are commonly in use and have been in use for many years.
Yeah, I agree with you. You would think sepsis would be an easy diagnosis to make, but the challenge is determining if a patient has an actual infection causing their organ dysfunction. Gonzalo, before we get into our discussion of the rapid multiplex panels, maybe you can review some of the different tests available to help us diagnose the etiology of sepsis, how they differ from each other, and then we'll look at some of the multiplex panels after that.
Great, thank you so much, Trevor. So essentially, with the rapid diagnostic testing, the goal is to minimize some of the guesswork that happens with empiric antimicrobials and to come to a more rapid and consistent and accurate diagnosis of an underlying pathogen that's driving the the process. Now, this is a busy slide and it has multiple different options for blood culture testing for suspected sepsis. But some of the big categories here to think of, the ones that are better known, such as the MALDI-TOF, which looks at subcultures tested from a positive blood culture. And the results are a targeted organism and identification with resistance patterns. And note that the turnaround time is about 12 to 24 hours from the culture positivity. And there's also another example of a test of MALDI-TOF that is similar in process. That also has 1 to 4 hours from culture positivity. Once again, with not so much a subculture, but a blood culture pellets. Now, if we look further into these potential options, there's nucleic acid amplification tests or rapid diagnostic tests, PCR tests, et cetera, et cetera. And you can see the various names of the examples or the commercial names. And these can test things such as positive blood cultures or even whole blood. We'll go through some of these in a little bit more detail. For example, the BioFire BCID2 Prove It test looks at the positive blood culture and can result a targeted organism identification and resistance patterns in 1 to 2 hours. Another one that's similar is nucleic acid amplification, Magiplex sepsis, Fungiplex Canada. Again, looking at whole blood this time, targeted organism identification and resistance patterns with a turnaround time of 3 to 5 hours. So essentially, what the theme is that with the rapid multiplex panels, you have a more rapid diagnostic assessment of the patient in a septic syndrome, with typically the organism being identified and not only having identification of an organism, but also having a sense of the underlying susceptibility pattern, which can later guide your antimicrobial therapy so that it is less empiric and more pathogen directed. There is one more I want to mention, which is at the bottom of this list, which is a shotgun metagenomics, also known as the Carius plasma test. It's whole blood and frequently referred to as a liquid blood biopsy. And this is quite powerful. It gives you non-target organism identification and resistance patterns. However, it does take 53 hours with respect to a turnaround time.
Thanks, Gonzalo, for that overview. This area, I think, seems to expand all of the time. What about the rapid multiplex bloodstream infection panels? What do we have available in that specific area?
Yes, thank you, Trevor. So let's take a look at an example. In this slide, we have the Verigene blood culture tests. And to summarize, you can see there's an entire panel of different organisms that can be identified, including gram-negative species, common ones including E. coli, Klebsiella pneumonia, and Pseudomonas aeruginosa, and also gram-negative genus, including Acinetobacter species, Citrobacter, Enterobacter, and Proteus. But here's an important component, that with these tests, you can also have key or important resistance genes identified, such as CTXM, which is for ESBL, then the carbapenemase genes, which include IMP, KPC, NDM, OXA, and VIM, or VIM. We also have the potential to identify gram-positive organisms, which include not only Staph aureus, Staph epidermidis, and Staph lugdunensis, but other things such as Listeria species, and of course the Enterococcus faecalis, Enterococcus faecium. In addition, with these multiplex panels, one can also get information regarding resistance genes, which are important to clinical decision-making and ultimate treatment options, such as MEK-A for methicillin, VAN-A for vancomycin, and VAN-B for vancomycin also. So a lot of powerful, important information, not only on the organism, but also the potential resistance profile. Mm-hmm. The other one to think of is a FilmRA BCID2. Again, looking at from the gram-positive and gram-negative bacteria. I'm not going to read all of them, but you can see this has really quite a broad category of potential organisms to be identified. But I do want to mention that there are yeasts also in this FilmRA, which include Candida species, albicans, Oris, glabata, cruzii, parapsilosis, and tropicalis. And once again, This particular approach also provides antibiotic resistance gene profiles, including the carbapentamases, colistin resistance, which wasn't in the previous profile. This is MCR1. ESBL is also measured by way of CTXM. Then, of course, methicillin resistance with MEC-A, MEC-A-N-C, and MREAG for MRSA, and, of course, vancomycin resistance also with VAN-A and VAN-B. So important information, again, not only with organisms, but also yeasts and antibiotic resistance genes. So the EPLEX BCID panels, and this is quite an extensive list. I'm not going to go through it all, but just understand that this panel really has a broad array of organisms with gram-positive, gram-negative, and we're actually a bit of an expansion of the fungal pathogens, not to include just the Candida species, but also Cryptococcus, Fusarium, and Rhodotorula. So you have an expansion of fungal diagnostic capabilities with this particular panel. One that I do want to also highlight is the T2 bacteria and T2 Candida blood panels. These panels are ones that are the only FDA cleared test to identify sepsis-causing bacteria and fungal pathogens in 3 to 5 hours. So once again, kind of a rapidity or a need for speed. And this is done directly from a whole blood specimen. So now no need to wait for the full culture result or the culture result and then have those subsamples analyzed. For the T2 bacteria panel, this includes Ephaeum, Staph aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and E. coli. And of course, for the Candida species, we have Candida albicans, Candida tropicalis, Candida krusei, Candida glabrata, and Candida parapsilosis. Note that Candida auris is not part of this panel.
Thanks, Gonzalo. It's quite a menu of tests available. So, Stephen, how do these rapid diagnostic tests for bloodstream infections compare to traditional testing methods? Do you have some data you were going to talk about?
Yeah, in a word, speed. If you're an ICU doctor like me, you always feel the need for speed because people are always sick. The slide we're looking at here shows an extensive literature review looking at all these various different types of tests that Gonzalo just told us about that compares duration of time it takes to diagnose or to detect a bloodstream infection, to identify the bacteria causing it, and to perform sensitivity testing. And so quite clearly you look at conventional cultures, and this is something that we've known how to culture bacteria for 150 years, and the test hasn't changed that significantly in that time. And this takes up to 120 hours before we're going to be fully satisfied that we either have the organism, understand what it is, and understand its sensitivities, or that we don't have an organism. Whereas some of these other tests that we were just talking about, the Luminex, the BioFire, etc., even MALDI-TOF itself is substantially faster, cuts that down. This is really important because in the ICU, we know that we sometimes are dealing with very serious organisms, very resistant organisms, and we want to be sure in our septic patients who are critically ill that we don't miss the important organisms. At the same time, if we can hone in and get our antibiotic spectrum down as narrow as possible, specifically treat a specific organism, we know our patients are going to do better. And that's how they compare. It's really time to make a determination, which is crucial in a critically ill patient. So Trevor, actually identifying pathogens is only part of the story. How is it that we test for antibiotic susceptibility in patients with sepsis?
Yeah, this is an interesting area that's really evolving. We started with rapid pathogen identification using particularly genetic methods and other techniques. But what a lot of physicians really want is real phenotypic susceptibility. What antibiotics will work? It's nice to know, is it MRSA versus is it not MRSA? But particularly for the gram-negative pathogens, because interpretation of resistance is complex, what we'd really love to have is which antibiotics is it susceptible to based on phenotypic susceptibility testing. And so there are a couple of systems out there that are available. One's called the Accelerate Phenotest. It's been available for a number of years. it can work with both gram-positive and gram-negatives, both identifies the bacteria and then provides phenotypic susceptibility results in about 7 hours directly from a positive blood culture. It can work for a panel of gram-negative organisms. Not every drug is covered for every bug, and so you should review that data on what's covered where. Another system is the Vitek Reveal system. This is a much more recently approved system. In this system, it uses similar plates as the microscan system, and volatile organic compounds are measured to measure bacterial growth, and you can develop a phenotypic susceptibility profile roughly 5 to 6 hours after having your blood culture go positive. Which means we're shortening that time that you talked about, Stephen, rather than waiting that 72, 96 hours to get a full phenotypic susceptibility. We're shortening that to the time to detection plus about 6 hours. And again, this panel covers a broad array of gram-negative organisms and agents covering a variety of MIC values, which is rather extensive, but not 100% complete for all the pathogens and agents. The last panel I'll just mention is called the Celux gram-negative panel. It was approved last year. 23 different gram-negative antimicrobial agents, numerous organisms. It's rather a large number of agents that can be tested on that panel, and it can be run directly off of a positive blood culture. That was just approved this year. So I think over time, we're going to see labs start to implement these rapid phenotypic susceptibility tests. So we've talked quite a bit about sepsis diagnostics and available panels. I want to move on to some case examples. Gonzalo, I think you have the first case for us. Can you walk us through it?
Absolutely. So this case may not be a huge diagnostic dilemma or conundrum, but I think it's important because it's a common situation which allows us to think about our antibiotics and think about how we would de-escalate and at what time. So the case is of a 29-year-old man admitted to the hospital with fever, malaise, and increasing confusion that evolves over 3 days. The past medical history is significant for being HIV negative, hepatitis C positive and treated with a history of intravenous drug use, does not consistently use clean needles, so still intermittently using drugs. The pulse is 124, the blood pressure is 90/55, respirations are 32, SaO2 is 92% on room air, it's diaphoretic with systolic murmur at tricuspid area, labs with a white blood cell greater than 15,000, the BUN and creatinine are elevated at 35 and 2.5, and the chest x-ray is with bilateral scattered infiltrates. So I'm sure many of you are thinking you know what the diagnosis is. And again, this is not a huge diagnostic dilemma. I will tell you the patient was admitted to the ICU from the ER with sepsis and treated with empiric vancomycin and piperacillin tazobactam. 3 of 4 admission blood cultures with gram-positive cocci reported, and that's rapid, within about 24 hours. And the transthoracic echocardiogram reveals a tricuspid valve vegetation. So the question is, how does molecular rapid diagnostic testing impact organism identification and the choice of antibiotics?
Yeah, I think that's a great question. Stephen, any thoughts on organisms, things you'd like to know, how you might use rapid diagnostics?
Yeah, first I would say that I think the ED made the appropriate choice with vancomycin and piperacillin tazobactam is a good choice because our principal organisms we're worried about in this case, before we get back to blood cultures, are gram-positive cocci and some gram-negatives, probably gram-positive cocci since this is a community-acquired, since this is a known IV drug abuser. We are likely to be thinking staphylococcus actually is what's foremost on our minds, but we've got to be thinking about streptococci, enterococci as well. So it's a good empiric antibiotic choice. Based on getting back to blood cultures with gram-positive organisms, my initial move here would be to move from piperacillin tazobactam down to ceftriaxone. One would be tempted, I would think, to possibly even go all the way to cefazolin, but we know about inoculum effects and so forth. And even though he's on vancomycin, probably safer to just back down to ceftriaxone, which would cover as well any penicillin-resistant organisms, streptococci that might be present. Gonzalo, maybe you have ideas about how the rapid diagnostic testing could help speed up the process.
So, Stephen, I think you're absolutely correct. The old ways is we would get called for an infectious disease consult and concur with the primary team that this is an infective endocarditis. And until organisms are identified and you have susceptibility profile, generally, most doctors would not want to make a significant change in antimicrobials. However, now with rapid diagnostic testing, you can have a greater sense of security in making the right diagnosis and choosing the right antibiotic. So let's take this example. If you have a rapid diagnostic test that confirms it not only gram-positive, but then further breaks it down to Staph aureus versus MRSA versus coagulase-negative staphylococci versus enterococcal species, that can guide your diagnosis and also guide your treatment. That could also help you de-escalate more promptly the piperacillin tazobactam or gram-negative agent. The presence of resistance genes such as MEK-A, for example, or VAN-A, VAN-B genes, depending on the organism, could also help you de-escalate your antimicrobials or appropriately adjust. In this situation, the most likely scenario is an MSSA infection, so cefazolin would be the appropriate antimicrobial of choice.
Mm-hmm. Mm-hmm. You know, I might add, and this is where it's good to know the antibiogram. In my own city, over 50% of community-acquired Staph aureus is MSRA, so we have to stay careful on that account too.
That is an excellent point, Stephen. And knowing your institution's antibiogram is absolutely critical, so you have a better sense of certainty as your choice of gram-positive coverage.
Yeah, I agree with you guys. I think the rapid diagnostic testing really helps you to target your antibiotics, knowing that if you can use a beta-lactam against Staph aureus, it's going to be more effective than using vancomycin. And so getting people on the right therapy faster is super useful. One question I have for you, Gonzalo, is how do you work this in with your interprofessional team? Do you have pharmacists or other people engaged with this, or the micro lab, and particularly the rapid diagnostics data?
Great question. I think for maximal use of these technologies, that you have to have an integrated process with microbiology, your antimicrobial stewardship team, and the infectious disease consult team, or the frontline providers. In our situation, 5 days a week, we have an embedded antimicrobial stewardship team member that's a pharmacist rounding with the ID team, always with a computer in hand with the updated microbiology data, and also have a direct line to the microbiology director to confirm any questions regarding the test results. So that way we feel much more comfortable being on top of the data, but also making decisions interdisciplinary with microbiology, infectious disease, and the pharmacy antimicrobial steward on the team with us.
Yeah, that's great. We operate somewhat similarly. All right, I'm going to move us on to our second case, which I'm going to present. It's a little different kind of a case than Gonzalo presented. I have a 78-year-old male who has coronary disease, heart failure, atrial fibrillation, is on anticoagulation, and has a variety of other medical problems, including chronic kidney disease and benign prostatic hypertrophy. In the past, he had a urinary catheter placed. It had been in place for a couple of months due to chronic obstruction, due to his prostate issues. The patient developed some discomfort and he felt like he needed to urinate, and so unfortunately he pulled the catheter out, not realizing there was a balloon present. So he presented to the ED with new onset hematuria and hypotension. A urinary catheter is placed. It had frank bloody urine, not surprisingly, and he was admitted to the ICU with hypotension. Interestingly, his laboratory finding, he had a white count of over 27 with 62% bands, a significant anemia, a procalcitonin level of 82. His chronic renal dysfunction had somewhat worsened. His creatinine was about 1.8, and he had a significant metabolic acidosis with an anion gap. It certainly sounds a lot like sepsis that we were talking about earlier. He was given large volume fluid resuscitation. He got 2 units of blood, was given a dose of vancomycin, and started on piperacillin tazobactam. He had 2 blood cultures drawn. Both were positive at about 12 hours for gram-negative rods. we used the BCID panel, and it was positive for Enterobacterales, E. coli, and the CTXM marker. And so I'm going to throw it out to you, Gonzalo, is what would you do therapeutically knowing those results?
We have a case here of clearly sepsis with bacteremia, and we have blood cultures that are positive, but now we have the luxury of having rapid diagnostic testing results. So Enterobacterales, E. coli, and CTXM. I'm focusing on the CTXM and also the absence of gram-positive organisms. So the first thing I'd say is the absence of gram-positive organisms is encouraging and would allow me to be more comfortable to discontinue medications such as vancomycin. The CTXM is a marker of ESBL resistance or an ESBL presence. So that would make me a little bit more concerned about continuing treatment with piperacillin tazobactam. So in this situation, I would make an alteration in the antimicrobials and really discontinue the piperacillin tazobactam and change it to a different antibiotic, such as imipenem silastin or such as meropenem.
Yeah, and that's actually what happened here. I agree. We think similarly. While some have suggested Pip/Tazo might be okay for UTIs, for any sort of serious bloodstream infection where ESBLs are a concern, we recommend as a stewardship team converting those people over to carbapenems. He was actually changed to ertapenem. And I think this case illustrates nicely how the rapid panels can help us to appropriately escalate antibiotics when we identify resistance patterns we hadn't anticipated. I think one of the interesting questions, and you address some of this, is with the gram negatives, how can CTXM markers help us with de-escalation? We know that CTXM isn't the only extended spectrum beta lactamase out there, but it is the most common in the US, and it can actually vary depending where you practice. And so one of the things we develop, because this is a question that's often comes up on our stewardship team, the blood culture shows E. coli, CTXM is negative, and they're on cefepime, piperacillin tazobactam, carbapenem, is can we de-escalate to a more narrow spectrum beta-lactam? And so we actually developed what we called a genotypic antibiogram. It wasn't our idea to call it that. There were some previous authors from Detroit and Maryland who'd done something similar. And we took our E. coli and our Klebsiella pneumoniae that were growing in our blood, and we looked at what was the susceptibility if the CTXM marker was positive versus if it was negative. And we created this genotypic antibiogram. And what we noted was there were very significant differences in susceptibility. It's not surprising. CTXM not only comes with the ESBL gene, but often carries other resistance markers with it. But in our E. coli, which were CTXM positive, 0 were susceptible to ceftriaxone. And in fact, virtually none were susceptible to Pip/Tazo and very low to cefepime. And so when we see CTXM, we recommend transitioning to a carbapenem. But we also looked at CTXM negative isolates. And what we found is if you were negative for CTXM and you had E. coli in your blood, 97% of those isolates were susceptible to ceftriaxone. And so we're, as a stewardship team, encouraging teams, we don't need cefepime, we don't need Pip/Tazo, we can de-escalate to ceftriaxone. Or if you started ceftriaxone, you can just continue to stick with it because that is our workhorse for pyelonephritis. Now that works for E. coli and for Klebpneumo, but in our institution, it doesn't work for all the gram negatives. And organisms like Enterobacter cloacae, Kleborogenes, Kleboxytoca, we actually recommend cefepime first line because of the presence of AMC and other resistance genes and just bad sort of baseline ceftriaxone susceptibility. In those organisms, if we detect CTXM, we do encourage bumping them up to a carbapenem if they had not been on that. But I think the key takeaway on this is that the Enterobacterales, particularly E. coli and Klebpneumo, can be a useful marker, particularly if you have some of your local epidemiology. And at our facility, E. coli and Klebpneumo that are CTXM negative, we are super comfortable using ceftriaxone. Our hospitalist teams are very comfortable using ceftriaxone. And the one exception is if a patient potentially has an ESBL history. And so we always do have to put that a little bit in clinical context. And so Stephen, thoughts from you on this case from a critical care perspective, gram-negative bacteremia, significant hematuria, hypotension?
Yeah, and so we don't know for sure based on the timing of the vital signs and so forth, but likely this is septic shock based on what we're seeing. So we are very concerned about getting the right antibiotic because, as we showed before, the wrong antibiotic in septic shock results in substantially higher mortality, and the longer you wait before you get that, the higher the mortality goes. Probably what would happen in the absence of rapid diagnostic testing is that we'd get a gram-negative rod, and we probably would think that piperacillin tazobactam, I think that's what he was on, correct? That would be an adequate antibiotic, and it would take us several days without the rapid diagnostic, or a couple of days at least, before we would understand that we're dealing with a resistant organism and need to go to a carbapenem. So I think this is really illustrative of an excellent use of these rapid diagnostic tests that may be life-saving for this gentleman.
Thank you. That's great. Stephen, Gonzalo, any final thoughts before we wrap this up?
Well, I would just add that with sepsis, there is, as Stephen said earlier, a need for speed, a speed in making the diagnosis and also speed for rendering the appropriate therapies. Rapid diagnostic tests can make the identification and even susceptibility identification of an organism much faster and allows us to also be more accurate with our antimicrobial escalation or de-escalation. But as we all know, knowledge is not always salvation. So it's important that we include our colleagues, not only in critical care, but also in antimicrobial stewardship to help us with the diagnosis and management of these complicated infections and to truly understand the antibiotic choices based on expert opinion and expert feedback. So those are my thoughts on rapid diagnostic tests in this situation.
Yeah, you mostly stole my thunder there, Gonzalo, but I will say this, that most ICU doctors are better antibiotic stewards than you would think. Simple reason is that we sometimes meet patients who have bugs resistant to all antibiotics. We also understand the history of sepsis before there were antibiotics, and we know just how deadly that is. So we hope to preserve the antibiotics we have. These rapid diagnostic tests help us get to the correct antibiotic faster. You will find, as a rule, that critical care doctors will use the broadest spectrum to start with because we know we can't afford to miss the organism based on the data we talked about before, but we're very good when we know that we can narrow that spectrum. We want to do it because we want to keep the antibiotics we have.
So great concluding thoughts. Well, Stephen, Gonzalo, it's been a great discussion. Thank you for joining me today. I want to thank you for participating in this activity. It's been great to have you. And please continue on to answer the questions and complete the evaluation.